no need to stay too long on organs of urinary system. Here also I mean like this, I may open for you to see. I'm talking about what? We have kidneys, ureters, bladder, and urethra. Location of kidneys is important. Location is important. Look, and size is also important. You have got everybody this lecture. So size is also important. Why? For example, on advanced stages of renal failure, we have shrinkage. And on ultrasound view, if we see that if, for example, it is less than 8 centimeters, 6 centimeters, it means we have glomerulosclerosis. Already even there is no indication for biopsy. We'll see glomerulosclerosis, and the risk of biopsy is higher. Where they are localized, look at the level of T12 up to L3. They are retroperitoneal organs. That's why mostly they are projected on the posterior wall of abdomen. Okay? And right kidney is a bit lower than the left one. Remember, normally they are not palpable unless they are enlarged, usually. Though in very thin individuals, inferior pole of right, especially the right one, may be palpable. But usually they are becoming palpable when they are enlarged. For example, polycystic kidney disease, tumors, hydronephrosis, and so on. And at top of each kidney there is an adrenal gland, this you know. Each kidney, pay attention, has two capsules. This is renal capsule and surrounding adipose capsule. We have surrounding fat tissue. Fat tissue is surrounding the kidneys. Inflammation of them is called, paranephritis, and it is becoming painful. Remember, kidneys don't have pain receptors, but capsule has, and also urinary bladder, urethra, urinary tract has, from pelvic region has. That's why in case of kidney stone disease, when stones will pass these microlines, or if we have hydronephrosis and enlargement and stretching of capsule, this will be painful. Pyelonephritis. Coverings, adipose capsule which is surrounding the kidney and renal capsule which surrounds each kidney. So first renal, then adipose capsule. Sorry. Adrenal. Очень, ну слушай, тебе только садик ambulance. Решала веб-сайт. У меня почти маншпес. Together we are using this power bank, and he is more than me. Horrible person. Look, now internal anatomy. I don't want this. I have here. Look, it's more than 150 slides. Half of them is anatomy physiology, just for you to revise. I'm not going to stand too long on this. If it's interesting, you may read at home. But main ideas are that. Look, we have three parts. We have cortex. Yes, medulla and pelvic region. Pelvis. And if you remember, medulla is giving us pyramids. It has, of course, a meaning, physiological meaning. Each of these types of nephrons will speak. Now this one is gold, but we managed to. It will work out today. These are functions of kidney. Even I don't want to read all of them, because to underestimate functions of kidney is impossible. It takes place in a lot of conditions. It's blood pressure regulation, first of all, electrolyte and water balance regulation, vitamin D synthesis, so hormone regulation, erythropoietin synthesis, synthetic function. That's why in case of chronic renal disease, in case of chronic renal failure, remember nowadays we are calling it chronic kidney disease. Instead of chronic renal failure, we are using term chronic kidney disease. Nowadays this term is different. If you tell chronic renal failure, everyone will understand, but it's not correct nowadays considered. But what concerns for acute renal failure, also we are using acute kidney injury. We are using them interchangeably, so both of them may be used. Acute kidney injury or acute renal failure. But instead of chronic renal failure, we are using chronic kidney disease. And chronic kidney disease has stages. Stages are given by GFR. We'll speak about this. Glomerular filtration rate, which normally is approximately 125 milliliters in a minute, or at least should be above 90. And based on this, we have grades 4 and 50. Decreasing, for example, more than 90 milliliters, then it's becoming up to 89. We'll speak. And the last one is when GFR is less than 15 or 20 milliliters. Remember this, it's called end-stage renal failure or end-stage kidney failure. Here the word renal failure already is used. End-stage renal failure. This end-stage renal failure has only one option. It is called renal replacement therapy. Richard, I'll kill you. Where are you? I have 2%, not I. Phone.
I am here, Dr. Arsen is right here.
Oh, okay. You should bring after 15. Sorry. No. You should bring it before Dr. It's my fault that he's the end. Okay, renal replacement therapy. Renal replacement therapy are two options. Either it is hemodialysis or it is transplantation. So, hemodialysis, I'm sorry that I used like Arabic alphabet from right to left, but hemodialysis or transplantation. There is also one more option, it's called peritoneal dialysis, when instead of this artificial kidney, whole peritoneum is used because it is semi-transparent membrane. But it is used in pediatric nephrology, so with a special device, like there is a pore, we're puncturing and inserting special solution, which is called dialysate, which contains exact amount of electrolyte, substances and so on. And it is staying for a while in the abdominal cavity, and what is needed is coming in, is not needed, is going to the bloodstream, and afterwards it is drained. It is called peritoneal dialysis, but it's not very widely used. It's one of the methods. Peritoneal dialysis. Anyway, it's also a renal replacement therapy method. Peritoneal dialysis. And remember, for you may be interesting, in your program, because it may cause pleural effusion from abdominal cavity. If you remember, they are not hermetically separated from each other. Especially on the posterior wall, alongside by the nerves and especially by the vessels, there are micropores. Fluid may travel there. Also remember that in case of pancreatitis, especially in the tail, yes, we have head, body and tail. If tail is involved, we may have left-sided pleural effusion. First of all, we have increased permeability. Second, per continuation, like as a continuing, as continuation of the process. Okay, So regulation of acid-base balance because hydrocarbonate buffers and so on and so on. Look, everything is written. Now, why I spoke about this? Because if we have already chronic kidney disease, especially advanced, almost always we have anemia because of the lack of erythropoietin synthesis. So these patients are pale. For the third-year students, it should be interesting and important because when you perform physical examination, on examination they look like pale. It's very typical for the pale. And we have to give them artificial erythropoietin, synthetic erythropoietins, erythropoietin beta and so on. One more interesting thing, morphofunctional unit of the kidney is nephron. Yes, each kidney has 1 million nephron. Now, the most important and tragic in this situation is that chronic kidney disease CKD becomes apparent when at least minimum 50% of nephrons are dead. One of my students a few days ago told that, for example, 1 million nephrons, yes. More exactly, more than 70%. So before this, if patient will not go check up, will not check creatinine level, I don't know, electrolyte and so on, maybe asymptomatic. So when they are reaching to a nephrologist, not too much is left to be done. So mainly they are doing hemodialysis or preparing for transplantation. And remember one more term, hemodialysis usually, not in all cases, but usually serves in chronic kidney disease as a bridge to transplantation, to win time, because you know it is taking time, you should find a donor, patients long time are staying on these waiting lists, so it is called bridge to transplantation. So this one is hemodialysis, is a bridge to the transplantation. Final solution of this is transplantation. And vasoactive substances, prostaglandins, and so on. Also, do not forget that renin-angiotensin system is there. A bit now we'll speak about this. This you are passing from I don't know how many subjects, even difficult to count. Biochemistry, physiology, pathophysiology, pharmacology, because all these chains are targets for medications. We have renin inhibitors, ACE inhibitors, angiotensin II receptor blockers, aldosterone inhibitors, and so on. Now look, let's start from the beginning. Renin. What is renin? It's an enzyme, proteolytic enzyme. Proteolytic enzyme which is produced by the kidney. By which part of the kidney? By juxtaglomerular apparatus or juxtaglomerular cells. Where they are and so on, a bit later is written, so. And it has a great role, RAS, in normalizing, in maintenance of blood pressure. So not only RAS, by the way, also by electrolyte and water regulation, this kidneys already, it's called barostatic role, because it's static, so barostatic, pressure static, keeping stable blood pressure. So RAS, how is working RAS? So juxtaglomerular apparatus releases renin. Renin is released in response to 3 conditions. Let's start from the less well known. This juxtaglomerular apparatus receives beta-1 innervation. It has beta receptors, beta-1 receptors. Accordingly, if we have sympathetic overactivity, it is increasing renin release. And vice versa, if you are giving beta blockers, it also will inhibit renin synthesis. It will not release, but synthesis, because they are synthesized well. Second, not only, it is not the only mechanism. Renin is released, this is very important, renin is released in response to pressure changes, yes? Low blood pressure. So we have baroreceptors. Baroreceptors. Baroreceptors in kidney. Not only in carotid arteries or arc of the aorta. And third, it is sensing some electrolytes, especially sodium level, When the lecture is written, for example, potassium chloride and so on, sodium level. Sodium receptors, yes. How this part is called? Where the sodium receptors for the sodium are localized to the kidney. This you are passing from histology. I forgot, also from histology you are passing this RAS system. No, remember this. Macula densa. Dense macular. This is between vas afferens and vas efferens. Now I'll show you. So this is macula densa. You see, this is vas afferens, this efferens. This is macula densa. So these are cells. In other words, these are chemoreceptors. Chemoreceptors, receptors for chemical substance. In this case, for sodium. In some sources, it's written high level, but usually they are sensing low level of sodium and activating RAS, renin release. What happens then? Renin is a proteolytic enzyme, yes? So it needs protein to act. Today we have classical lecture as it was 50 years ago without anything. Just blackboard, piece of chalk, teacher and students. Now, renin. Renin is acting on angiotensinogen. Let me write down like this. Angiotensinogen, which is synthesized by liver. Because it's a protein, and most of the proteins are synthesized by the liver, including this one, angiotensinogen. Renin is acting on angiotensinogen and converts it to, by taking some endings, yes, protein. Angiotensin 1. Angiotensin 1 is not a stable product. Very soon it is becoming angiotensin 2. This is by angiotensin converting enzyme, which mostly is in the lungs, lung endothelium. Okay, not in the alveoli. Inside. Angiotensin 2. Angiotensin 2 then is becoming angiotensin 3 and 4, but they are also not living too long. They have short half-life. So scientifically they are studied, but clinically up to now, as far as I know, they don't have meaning, so we'll not speak about them. To be honest, I didn't know too much about them, only that they are not living too long. There were some publications about their role, but anyway, so angiotensin 2 already has two directions to go. One, it is the most potent vasoconstrictor agent. Through the vasoconstriction, increases blood pressure, especially diastolic. Why? Because diastolic was due to total peripheral resistance. And total peripheral resistance is due to the tone of small vessels, arterioles. So arteriospasm, and thus diastolic blood pressure increases. From one end. From another hand, it is arriving to adrenal glands. Cortex, cortical layer adrenal glands, and releases, remember, it's already synthesized there, releases aldosterone. Aldosterone release. Aldosterone is a mineralocorticoid. Sometimes it's written by K. Mineralocorticoid. Mineralocorticoid is regulating minerals electrolyte balance. Particularly, it is retaining sodium and thus water, and it's treating potassium. So, aldosterone release, which results in sodium and water retention, yes, and thus, especially systolic blood pressure increases circulating blood volume or plasma volume, and thus systolic blood pressure. Of course, normally we need it for the tone, for the blood pressure. It's another question that if we have overactivity of sympathetic nervous system, so on and so on, we may have primary and secondary essential and symptomatic hypertensions. And that's why in most of the kidney problems we usually have blood pressure problems, increased blood pressure. Remember that very typical also is that diastolic may be too high. For example, 160 over 120. And we have short, brief, last semester we spoke, not like brief stabilization on high values. For example, if for primary hypertension we need years usually for 140 to become 150, 60, and these are mainly already after middle age. These patients are young, maybe at the age of 20, 25, 30, and they are telling you, doctor, you know, in recent 2-3 months I felt that I'm not feeling well, I measure blood pressure, it is for example 160 over 120. So this also should be taken into account. Now, about each of them we may speak, just I don't want to speak about pharmacology and so on, but remember, just in case, though I think from pharmacology also. Sometimes we may use ACE inhibitors, but blood pressure, which initially was responding, so it was lower, starts to rise. One option that yes, okay, disease is progressive, but sometimes it is related to so-called escape phenomenon. Escape, like angiotensin converting enzyme. Angiotensin, this RAS is escaping medication. How? We cannot check too long on the organism. If we are inhibiting something, organism finds a way to synthesize them. So when we inhibit ACE, there is, for example, also tissue angiotensin converting enzyme. This is in the bloodstream. Also, there is a enzyme, kinase, which again is responsible, I'll show you, for angiotensin 2 to angiotensin 1 to 2 conversion. Look, cathepsin kinase. There are others. So, kinase is doing the same as ACE. ACE is inhibited, but still we have angiotensin 2. What to do? One of the options is to remove ACE inhibitors and instead to give angiotensin 2 receptor blockers, because it's already final target. Second, you may add angiotensin 2 receptor blockers. Just for the third year, we're not speaking about the treatment, but this is important issue. Remember, ACE inhibitors and angiotensin 2 receptor blockers, they have almost the same indications, contraindications, and side effects. But angiotensin 2 blockers are not causing dry cough because they are not inhibiting, they are not related to bradykinin synthesis. Look, here I don't have shown. And also, we have kallikrein system. It's another system. Yes? And there is an enzyme. It's called kinase 2, kinase second, which is from bradykinin. Is making inactive metabolites. So inactivating bradykinin is kinase 2. Now, how is it related to RAS? Directly, this kinase 2 is the same as ACE. Just in this system, it is called kinase 2, but the same angiotensin converting enzyme is called kinase 2 in kallikrein bradykinin system, and it is destroying bradykinin 2 inactive metabolites. Accordingly, when we inhibit ACE, it means that we inhibit also kinase or kinase 2. What happens? It happens that we have bradykinin accumulation, which gives extra vasodilation. It increases, yes, permeability. But In some people, we may not say in whom. In up to 20-30% of cases, those who are receiving ACE inhibitors, they have dry cough. Why? Because it may irritate receptors in the respiratory system, this bradykinin, due to increased permeability of vessels. In this case, we have to remove ACE inhibitors and give angiotensin II receptor blockers. Okay. Look from where to where we came. This is the same. Angiotensin G, angiotensin 1, angiotensin 2. We have two types of receptors, by the way, angiotensin 2 first type receptors and second type receptors. They have various effects. Usually we have medications for the first type receptors. They are marked like these. Angiotensin 2 first type receptors, first subtype. These have ending sartan, like sartan, neprosartan, andesartan, telmisartan in India, very widely used. Telmisartan, yes, anybody has hypertension, as far as I see prescriptions, almost 90% are receiving telmisartan. It's not a bad medication, but for example, one of the side effects of statins, sartans, was their higher cost. In comparison with ACE inhibitors, they used to be 3-4 times higher in price. But nowadays we have cheaper analogs, and this difference is decreased between them. From pharmacoeconomic point of view, for example, pharmacy faculty students are asking subject is called pharmacoeconomics. That in side effect it's written high price. Yes, it's high side effect if you prescribe, the patient will not be able to get. Very often we are giving ACE inhibitors, but there are places where they are irreplaceable. Okay, as for example by angiotensin 2 second type receptors, it is we have apoptosis and so on. That's why in heart failure we were giving ACE inhibitors, because angiotensin 2, catecholamines and so on, they have a remodeling effect. Unfortunately for you. Now, anyway, until I turn on, the lecture will be over. I'll try it first. So, blood flow in the kidneys. If you remember, we have recta mirabile, wonderful network. Wonderful network, which means that how, like for the liver, yes, normally we should have artery entry and vein should come out.
Yes.
Here in glomerulus, because kidneys also have veins, in glomerulus we have arteriole entering and arteriole coming out, vas afferens, vas efferens, or afferent or efferent arterioles in English. Of course, it is taken from Latin. Now, this is the structure. From aorta, we have renal artery. Renal artery is becoming segmental artery, lobar, interlobar, artery, interlobular, and afferent arteriole rises from there. We have capillaries, in glomerulus, and from glomerulus is coming out efferent arteriole, peritubular capillaries and vasa recta, so direct veins, interlobular vein, arcuate vein, interlobar, renal and vena cava inferior. So yes, again, we have blood from going the vena cava inferior system. But exactly, glomerulus we have arterial blood, arterioles. Anyway, on the larger screen, I think will be more beneficial for you. циркуляционная степень. Ага, да. Да, молодец. Есть этот положение, да. Это корпус, да. Кажется, we were speaking about this. Aorta, offer arterial, glomerulus, blood flow in the kidneys, nephrons. Look, this is the most important one of the most important points here, because we have nephrons. Nephron consists of vas afferens, vas efferens, and they are covered by Bowman's capsule. Also, we have consists of renal corpus called renal tubule, corpus called not of capillaries, which is called glomerulus, and renal tubule. Already we have proximal, distal, a loop of Henle's loop, distal convoluted tubules, and so on. What is the meaning? The meaning is this: that we have three processes from the primary urine to have secondary final urine: filtration, reabsorption, and secretion. For the filtration, we have something here, they have called it, and I have taken, it's called net effective filtration pressure. Let's speak about filtration pressure. Filtration pressure is defined by this equation. Peak filtration, or net filtration pressure, is equal to hydrostatic pressure minus oncotic or colloidal plus intracapsular or intraglomerular. In other words, it is the pressure difference between vas afferens and vas efferens. On vas efferens, there is angiotensin II receptor, and when it is binding with its receptor, angiotensin II, we have vasoconstriction, and it contributes to filtration. Hydrostatic pressure is blood pressure in that part. Accordingly, if we have low blood pressure, we may not have enough filtration pressure, because while subtracting from low hydrostatic pressure, the result will be low. And it has been calculated that blood pressure, this systolic, minimum systolic blood pressure should be 90 millimeters of mercury per minute for us to have normal filtration pressure. That's why in shocks, in cardiogenic shock, okay, for example, that's a complication of acute myocardial infarction. Last semester we have spoken about Phillips classification failures. 4 classes. 4th is called cardiogenic shock. 3rd was internal, pulmonary internal. Now, due to sudden decrease of stroke volume, where myocardial infarction, stroke volume suddenly decreases, drops. It means that blood pressure drops. We have hypoperfusion of the kidney. As a result, we will have not enough filtration pressure, and it will give rise to nitrogenous waste products will be accumulating, potassium will be accumulating. It is called acute renal failure. So, in cardiogenic shock, which is acute left ventricular heart failure, acute left ventricular heart failure, caused by acute, yes, cardiogenic shock, results in acute renal failure. This is so-called pre-renal form of acute kidney injury or acute renal failure. And patients may die of this. So this is why, for example, even if you are a cardiologist, you should know nephrology enough well to understand what is going on. Because if your patients create an imitation, you start to rest for you to understand that it's on the background of cardiogenic shock, for example. Okay. And also, now look, this is net outward pressure, glomerular capsule, capsular hydrostatic pressure in the exam. About filtration rate, we'll speak now. We have two types of nephrons. Cortical nephrons, logically they are in the cortical layer, and juxtamedullary nephrons. What is their difference? Not only location. Most of the nephrons normally are cortical nephrons. Juxtamedullary, this is on this borderline between cortex and medulla, look here. And their loop of Hele is going into the medulla. But if for some reasons we have damage to the cortical nephrons, blood is circulating through these juxtamedular medullary nephrons, which is not beneficial. We'll speak when speaking about signs and symptoms. In kidneys, there is one wonderful system, not only this is explaining the juxtamedular apparatus, how RNA is released, sympathetic stimulation, pressure receptors, and macula densa. In chloride, potassium, sodium ions, but mainly sodium, especially sodium. In kidneys, look, we have filtration, yes, reabsorption, secretion. We have a system which is unique. It's called counterclockwise, yes, a multiplicating system. What does it mean? That, yes, we have proximal, distal, loop of Henle. Different parts of nephrons have different permeabilities for various substances. Or vice versa, various substances may enter or may go out from different parts. Due to which kidneys are able to produce more concentrated or more diluted urine. It is very important. For example, look, if we have polyuria, more than 3 liters daily urine output, or if patient has taken too much fluids, you'll pay attention that their urine color is light, because kidneys don't have time to concentrate. And vice versa, in cardiogenic shock, in shocks, we may have no urine output, which is called anuria or oliguria or oligoanuria, in less than 400 milliliters or 500 milliliters, depends upon the textbook. Oligoanuria, even if you'll see little amount of very dark urine, even it may resemble hematuria, like RBCs in the urine. But in reality, it is highly concentrated urine. This has become that. It is due to this wonderful system, which, primary urine is 150 to 100 liters per day. The secondary final urine output is, for example, 1.5 up to 2 liters. Remember these terms a bit later we'll speak, and maybe not even today. More than 3 liters is called polyuria. Less than 400 milliliters or 500 is called oliguria. Less than 100, 150 milliliters anuria. In slang we are calling it EPS, like Epsom. In mineral ups. Because to have 50 milliliters is the same as to have a whole. But they have already great clinical meaning. Now I'll explain this part, you will read. It is explaining which part from which, and about this I will speak. And antidiuretic hormone. Why changing permeability in the distal part? Yes, of tubules is really good. Antidiuresis. So we'll have less urine output. Look, materials which are not reabsorbed, urea, uric acid, creatinine, all are nitrogenous waste products. But very often in clinical practice we are taking into account creatinine. Why? Because creatinine is less dependent upon the protein intake. All are protein metabolites. But urea is more. That's why we are taking creatinine, and to be honest, we are not taking only creatinine, we are taking GFR, glomerular filtration rate. Secretion, this is formation of urine, distribution of body fluid, we have intracellular fluid, extracellular, yes, and extracellular in its turn, this is interstitial and plasma volume. You know that 60% of body weight is water. In between water and salt, you'll read, and again, acid-base balance. Ureters. Urinary bladder. Urethra. About this, we speak. that without this we may speak. Look, urethra. Urethra has difference in males and in females, and clinically it has a great meaning. Females from the age 1 up to 40 years, so the reproductive age, are more likely to have urinary tract infections, cystitis, urethritis, because it's a ascending infection, up to involvement of pelvic region, which is called pyelonephritis. Pyelos is the same as pelvis. One is in Greek, another is in Latin. So females are more likely, especially young females, to develop pyelonephritis and urinary tract infections, UTI. Why? First, female urethra is short and wider, shorter and wider. So for ascending infection, it's more convenient to pass through it in comparison with the males. Second, it is between anus and external genitalia. So it has two gates for infection. From genitalia may come and from the GIT. These are two main factors. Next, in pregnancy, it is so common that it's called pyelonephritis in pregnancy. Special variant of pyelonephritis. Why? Besides this, all what I told you, this urethra also enlarged uterus compresses against this urinary tract. And for ascending infection, it's more beneficial. This peristalsis is impaired. Also, in pregnancy, we have estrogen, progesterone, this background is changed, progesterone is increased, which is changing urine pH to more alkaline. Meanwhile, for most of the bacteria, urinary tract infections mostly are bacteria. Acidic environment is killing them. Alkaline is more beneficial. So, remember these differences. In males also is possible to have, it's not that cystitis or possible, but after usually 45, 50. Why? It is related to prostate gland. If you remember, part of the urethra is passing through the prostate. Prostate is surrounding. It's called pars urethralis, urethral part. And if we have inflammation, prostatitis, benign prostate hyperplasia or prostate cancer, it is narrowing this urethra, and for the ascending infection it is becoming already beneficial. But usually it appears in males after 45, 50, 55. That's why pyelonephritis is more typical for them. Even one more, it's called pyelonephritis during the first sexual contact. It's called postcoital or defloration pyelonephritis, due to the impairment of the continuity of the layers and ascending infection. So from the external environment we have infection, and due to above mentioned factors like short urethra, wide urethra, we may have pyelonephritis. Up to 1 year, males, females, like newborns, is the same to have. But after 1 year to 40 years, usually females are more likely to develop urinary tract infections, which includes urethritis, cystitis, and of course pyelonephritis. By the way, for pyelonephritis, only bacteriuria is not enough. There is also refluxes we need. One reflux is from urinary bladder into the ureters. So we should have backflow. And second is already from that pelvic region into the kidney, inside the kidney already tissue. So we'll speak again. Now we are speaking about general part. So look, these anatomical considerations help us to understand clinical manifestations. Okay. On this, let's finish today. At home, please complete all this anatomy, physiology part up to signs and symptoms. Then we'll continue from signs and symptoms. Okay. A few more slides I need to explain, but next time. Okay. You may go.